I really appreciate everyone coming out tonight to see this, because this is a device and a procedure that I've been doing now for a little over a year, and that's basically, it's a new device. So nobody really has experience beyond 2 years, because this is recently FDA approved, but I've been very, very pleased with the outcomes that I've had. And so this is something I'm glad I have an opportunity to talk to all of you about this, because I think this is something that really has an opportunity to help a lot of people, which is, you know, in my world and what I see, this disease, BPH, really affects people's quality of life in a negative way. So to have treatment options that are minimally invasive, easier to administer, easier to recover from is very attractive. This is just the anatomy of the prostate. These here are the kidneys, this is the bladder, this is the prostate, and then this is another picture with the bladder here and the prostate. This is the urethra here, and this is what you urinate through, from the bladder through the urethra. This is the penis, this is the prostate. One of the ways that I like to describe to people why the prostate causes urinary problems is, I think it's a good way to describe it is the male anatomy is kind of a design flaw. It's actually designed very poorly. The prostate is, its function is for reproductive function. Prostate has no other function besides reproductive function, and you know, by the time you hit 40 years old, you really don't need it anymore. It doesn't do any good for you. It just causes a nuisance. And it's a gland, so over time it grows and it grows and blocks this area up, and I'll show you in another picture in a second, but basically what we need to do, and what this procedure, and there's lots of other procedures similar that do this, we try to relieve that obstruction so that the urine can pass through easily. This right here is what every one of you men looked like when you were 30, okay? So this is, you know, a wide open channel. This is what we're trying to accomplish for those of you that are dealing with this disease now. And this is kind of what it looks like now. So you can see that this bladder is more full, and the channel you urinate through is really, really tight. So you're trying to get a stream through this really tiny little channel. I don't know if any of you are plumbers or have some knowledge of plumbing, but that's not working too well. And so that's what we're really trying to get you back from this back to this. And that's what this procedure does. This is a really common condition. And, you know, basically most men, as they reach older ages, 70s, 80s, you're going to see that almost all of them will struggle from some urinary complaints, some urinary problems. And there's lots of things that we can offer people. But, and this slide says 14 million men that have been diagnosed with BPH. It seems like a pretty low number to me, and I think the reason is that a lot of men don't seek care, support. They're being diagnosed incorrectly, and so there really is so much of a need for treatment here. And you know, it's been something that we've been treating for a long, long time, but it's really nice that we have some new tools available to us to help men that are suffering from these conditions. 50% of men between the ages of 51 and 60, 90% of men over the age of 80. So, as you can see, really, really, really common disease. And in its latest stages, it can affect kidney function, some association with prostate cancer, but not a lot. But it's, by and large, this is a disease, it's a quality of life disease. So this is something where, you know, you can't get out of the house because you can't drive anywhere. You can't go to a restaurant. You can't sleep at night because you're waking up all the time. And so this is much more a quality of life disease than it is a disease that's going to shorten your life. But it's absolutely has a profound effect on quality of life, and that's why we're so concerned about it. All right, so these are some of the symptoms of BPH. And by the way, I don't know if I said, BPH stands for Benign Prostatic Hyperplasia. And also, you see that LUTS is also written up there, lower urinary tract symptoms. And so these are some of the terms that we use in the field to try to describe what patients are complaining of, what they're experiencing. And these are some of the symptoms. Frequent urination, especially at night. Urgency to urinate. When you feel you got to go, man, you got to run to that toilet. You don't have any lead time at all. you have a tough time starting urinating, you got to push, your stream is weak, you dribble afterwards. And these are things that I hear every single day in my office. And I'm sure that a lot of you, the people that are here today sitting in this audience, are experiencing this. So this is, I mean, this is what I do. Every single day I hear these kind of complaints. And so, and you know, it's very gratifying to be able to help people with these complaints. What do we do when we have someone that comes in complaining of these symptoms? And frankly, I think it's absolutely the most important part of diagnosing this is the history. What are people telling you? That last slide and the things that they're describing is really what I want to know, because as I said, this is a quality of life disease. What is affecting your life in a negative way? How can we help you? So there are these other tests that are mentioned here, cystoscopy and trust, and I'll absolutely do this for every single patient that gets a Rezūm treatment, has a cystoscopy where we look in the bladder with a scope. They have a trust transrectal ultrasound to measure the size of the prostate, and I think it's critical that we do both of those things to appropriately plan and identify who is a good candidate for this treatment. Urine left in the bladder, you know, I think every one of you here is a patient in our practice, and you know, you may have noticed that where we do this test where we put an ultrasound probe over the bladder and see how much urine is left behind. And it's something that's useful to assess the severity of somebody's BPH. The flow rate is a test that can be done. I don't do it as much. The prostate size, again, you're going to figure that out by that trust transrectal ultrasound. And there's a questionnaire, and that's the International Prostate Symptom Score, that IPSS that's up there, to assess the severity of somebody's symptoms. This is an important slide to let you know that there's lots of different things we can do for this. So I don't want any of you to think that Rezūm is your only option for the treatment of BPH, because it's not. And in fact, the majority of my patients that I treat for BPH don't get a Rezūm. But it absolutely is a very nice addition to the armamentarium of what's available. So behavior modification, fluid and diet changes, and one of the biggest ones, I mean, certainly a major complaint that people have is waking up at night to urinate. 5, 6, 8 times. For some people, 3 or 4 times is very, very bothersome. And one of the things that works great is just to really limit your fluid intake at night. That makes a big difference. And you know, certainly I encourage people to do that as they're experiencing waking up at night more. Coffee, you know, we were trying to trick you guys a little bit. We had you have coffee before you. That can affect how frequently you urinate. Alcohol. So there's a number of different things that can increase your urinary frequency during the day as well. Watchful waiting is, I'm not sure what exactly they're referring to there, and Kegel and bladder training. I'm not convinced that that's terribly helpful in this as either. Far and away, the first line treatment is medications, and a lot of you are probably on these now. Medicines like Flomax or Tamsulosin, medications like Proscar, finasteride. These are like the hallmarks of our treatment, and these medicines we've been using for a long time. 20, 30, 40 years we've been using these medicines, and they work great. They work great. But they don't work for everyone forever. So, you know, you get to the point where these medicines aren't enough. 30 years ago, you had these, the medicines I just talked about, and you had this called a TURP. So this is a surgical procedure. And that was what was available. And TURPs work excellent too. But, you know, TURPs have become much less common today. So TURP is an invasive procedure where you pass a scope into the bladder and you cut out, it is this electrosurgical device, you're cutting out all the prostate tissue. And it works terrific. But it really is not anywhere near as commonly done today because there's a lot of risks with it. There's a lot of bleeding associated with it. You have to stay overnight in the hospital with it. There are some complications associated with it. And so consequently, you know, 30 years ago, I wasn't practicing then, but I know my colleagues were asking, what else can we do for our patients that, you know, where either TURP or these medicines, what else is available? And consequently, a lot of different things have been developed. I do a lot of lasers to the prostate, and that's really an excellent choice as well. But again, it does require being put to sleep. It does have a higher bleeding risk. You have to go to the hospital. So it's certainly a more invasive option. There's microwave thermotherapy. I've been doing that since I've been in practice, and that's it's an office-based procedure. But it takes a while. It takes about an hour, and it's definitely not as effective as the Rezūm is. And so, a lot of my patients that were getting microwaves are now getting Rezūms and having better outcomes. This implants here, there's a new procedure that was released roughly the same time as Rezūm, and it's certainly another option for patients. Although it does have its limitations, only certain patients with certain anatomic types are candidates for it. And which brings us to the Rezūm. And that's what we're talking about today. And that's, as I said, a very attractive alternative because you're getting a lot of the benefits of this without the risks, without the need to go to the hospital, without the need to be put to sleep, without the need for any significant risk of bleeding. And these are all very attractive options and actually some sexual side effects that you get with these that you don't have with the Rezūm as well. And I'll get to that in a second. So kind of touches on what I was saying. Our mission is to transform your treatment experience. And yeah, I mean, as I said, I think one of the real attractive things about Rezūm is that it's just a lot easier to do than where I was talking about those lasers and the TURPs. It's just a lot easier. And it's very attractive that you don't have to go to the hospital. You don't have to be put to sleep. You don't have any real significant risk of bleeding, and that's sexual side effects. These are all real benefits of Rezūm versus other treatment options. So how does it work? And I'm going to show you a video in a second which will explain it better, but frankly, it entails just we use a scope, we pass a scope into the bladder, and we numb up the prostate, and then the scope has like a little needle on it that we put into the prostate and inject water vapor into the prostate. Just a few drops of water, and that's all that you need. And the rest takes care of itself over a 3 to 6 month period of time. So it takes a while to get maximum benefit, although generally patients are noticing a difference within a couple of weeks, starting to notice a difference. All right, so here are some of the benefits of Rezūm. It's an alternative to BPH medications. I will comment on that I think these slides were made by the company, I should tell you. So not all of what's here may absolutely totally accord with my line of thinking. And I think if you're doing well on medicine, I think you should stay with the medicine because it's a procedure. There's risks, there's issues. So if you're doing great with the medicine and you're happy with it, I personally don't tend to try to encourage patients to go to this procedure, although it absolutely is an option. But I think these medicines still have a major role. They're very valuable, and I personally don't encourage patients to get off medicine to do this treatment. But I would say the majority of patients feel like on the medicine they could get a little bit more. They could be a little better than they are, or maybe a lot better than they are, and that's where all of the procedures that you saw on the slide two slides ago come into play, and why Rezūm, I think, is such an excellent option. It provides, as I said, within 2 weeks you're going to start to notice some difference, some improvement. In office, as I said, you don't need anesthesia, you don't need to go to the hospital, doesn't need anesthesia. Sexual side effects. Basically, I think, this is as good of a time as any to talk about the sexual side effects. So with the medicines that I was mentioning, with TURP, with laser, some of these other treatment options that are available for the treatment of prostates, one of a number of big downsides, for those men that are sexually active, they often develop a condition called retrograde ejaculation. And what that means is when you ejaculate, the semen goes backwards into the bladder rather than out through the penis, and so it's like a dry ejaculation, some people call it. It's not a huge deal, I don't think, and most of the people that are having Rezūm procedures or TURPs or lasers or even those on medicines are not trying to have more children, so that's usually not a significant concern, but a lot of people don't like it. A lot of men don't want that, and Rezūm is great because it has very negligible retrograde ejaculation, which is, as I said, a real negative side effect to some of those other treatments that are available. And allows patients to return to regular activities within a few days. You know, I think that's a little overstating things. You know, in my hands when I do a Rezūm, I do keep a catheter in the bladder for 3 to 4 days. And frankly, patients don't like catheters. I don't know, probably some of you in this room have had catheters and not crazy about it. So during that time, you know, some people are quite bothered by it. Generally though, when we get the catheter out, you're, you know, pretty much fully recovered at that point. So it's not, once that catheter comes out, you're feeling great. You know, there's not really much more recovery after that time. So the, about 2 hours total time. You know, again, these slides were not made by me. In our hands, it takes a lot less than that. Usually our patients arrive for the procedure, and it talks about it down here. We do, as I mentioned, this prostate block, transrectal prostate block. Wait about 10 minutes to allow that to take full effect, and then do the procedure. And frankly, assuming everything's running on time, from the time you arrive to the time you leave is about 45 minutes. So it's pretty darn quick. I mean, it's 2 hours, absolutely not in our practice at Greater Boston Urology. The procedure itself is about 5 minutes long. As I said, we're inserting these needles into the prostate. It's a 9-second treatment, and we do multiple treatments, 2 or 4 or 5, depends on everyone's specific anatomy, but just a few treatments. And as I said, you will have a catheter for a few days, and we talked about that, the transrectal block of the prostate.
You need to know where every bathroom is within a 5-mile radius of wherever you are. You know, I remember there was a time when we were in Spain and the people we were traveling with were saying, you know, he's always going to find the bathroom. And I always had to. I had pretty well was resigned to the fact that I would have to take medication forever. Well, first of all, it was really expensive. You know, even though I have Medicare Part D, it still was an expensive thing. Plus, you know, it makes you dizzy, and I'm not so sure I wanted all of that stuff in my body. And so then I made an appointment and said, you know, I've read your brochure and I'd like to consider this. So had a conference with the physician. And, you know, he didn't push me at all. He said, you know, I want you to think about this. And so, you know, I did that, went home. I talked about it with my wife, and I said, I don't see where this is going to lay me up. You know, this should be something that's going to work really pretty well for me. And so I went back to the doctor, made an appointment. And, you know, I don't think I was at the clinic for more than an hour. It didn't hurt. It felt weird, but it didn't hurt. I first started feeling relief from the symptoms probably 3 weeks after the surgery, because I had to gradually get off of the Flomax and start taking those pills every other day because you just can't stop with those for 2 weeks. And the Avodart, my urologist said, take it until it's gone. So when it was gone, I was free. Since my Rezūm procedure, I've been able to be free of having to know where the bathroom is right away. I don't have to take pills, and I don't have to pay for them. When I do get up at night, which is about once a night, and I think that's pretty normal, I'm not dizzy. I don't feel like I have to hold on to something. It just kind of really works beautifully. And there have been no side effects. My God, to have the freedom. This is really what has been the end result, is freedom. Freedom is a big thing. I would really say this sets you free. And when you're 75, like I am, that becomes a really important issue. I would say to my friends, and have, about the procedure. It's easy. And if you're thinking about it, do it. It gives you the freedom that you never thought you would have again.
So, you know, when you're asking yourself, is this a procedure you want to engage in? Are you tired of the BPH symptoms? I'm guessing most of you are. That's why you're here tonight. Is the medicine not working for you? Very commonly, it's what we see. Is it not working for you? And you know, every person decides working differently, but you may want more treatment, better treatment than you're currently getting with the medicines. The surgical options are more invasive than you want. You don't want the bleeding risk. You don't want to be put, you know, given anesthesia. You don't want some of the long-term risks, the side effects, the retrograde ejaculation. And that's where Rezūm fits in. And we have appointment cards here. You can go to our website and learn more about it as well. You see our phone numbers on there. And that's it. So I'll take a couple questions if you have questions about the Rezūm procedure or really anything else that you'd like to ask about. During the procedure, and I'm not going to tell you it's pain-free because it's not, you do feel it, but we do this thing called a prostate block. And so we really numb up the prostate area very, very effectively. And so the actual procedure itself is very well tolerated with that block that we use. With the catheter, you know, the catheter drains your bladder into a bag, and we provide you with a bag that you wear on your leg underneath your pants. And so basically, you know, nobody's going to know that you have the catheter in because, as I said, it's sitting underneath your pants. So because of that, you know, it's pretty discreet. They're not comfortable, and you know, I don't want to sugarcoat this at all. And you know, I would say that a lot of patients will say that's the thing they like the least about this whole experience is the catheter. Although some of you in this audience or other patients that end up having a Rezūm have had to have a catheter at some point. They couldn't pee for some reason, or so you know, a lot of you may have been exposed to catheters in the past. You know, there really are no meaningful side effects. I mean, as I said, early on you have the catheter, you can have some bleeding, not a lot. There is this risk of this retrograde ejaculation that I told you about, but the risk is extremely small. No, I mean, you know, there really isn't any meaningful downside of having this procedure other than, you know, in the first week that you have it done. Different people have different responses, and you know, I've had patients that have recovered faster. I had one patient that had a tough time urinating for about a month afterwards, and so there are risks to it, like any procedure. However, the vast majority of patients will tell me at their first visit that I'm going to see them after the procedure in 2 weeks, they're already really happy that they had it done, and they still haven't even gotten more than maybe 25% of their symptomatic improvement at that time. If you have Medicare, then you know it's 80. You know, that's 80% covered. If you have a secondary, it should be fully covered. If you have private insurance, you know, you may be affected by your deductible, but it's covered by all insurance plans. So no, they're really outside of what your deductible is or co-pays, it's completely covered. Can you bleed from a catheter? Yeah, you will. I mean, you know, catheters are irritating, and so they kind of, you know, they bump up against the wall of the bladder and they can lead to some bleeding. I mean, generally, no, you're not going to take out a catheter and bleed a lot unless it was done wrong or something. I mean, it has this balloon thing on it that's how it stays in the bladder, and if whoever removed it didn't deflate the balloon all the way, yeah, you'll bleed a lot. But generally, no. So typically what I do is you know, so we'll do the procedure. I typically do them on a Monday, and we have patients come to the office on either Thursday or Friday to get out the catheter. I recently had a patient just a couple weeks ago whose daughter was a nurse, and he took it out himself. You know, she took it out for him there. Yeah, I mean, if you're comfortable with removing catheters, you can do it yourself. I mean, there's not rocket science by any means. But typically patients will come to the office and have their catheter removed a few days after the procedure. What happens over time with prostatic hyperplasia is that the prostate cells grow and grow and grow in response to testosterone. And so when we inject the water vapor, we're injecting heat, very, very, very hot water into that area. And essentially what you're using, it's a big word, it's called apoptosis. But the body has a way of getting rid of dead tissue and through cellular immune response. And so we're killing a lot of cells by injecting this water vapor. And then over time, the body absorbs all of that and consumes it. And if you remember from that slide we looked at before early on, opening up that channel so you can urinate better. Well, that's an excellent question, and you know, I tell my patients that I don't know the answer to that, because as I said, this is a very new procedure. So, you know, it was only FDA approved in the past, you know, 2 to 3 years. Okay, so we're gonna have to see on that. I would expect that the outcomes would be similar to these. You know, I'm talking about the laser procedure. So, you know, in a laser procedure, I generally tell patients you would expect to possibly need another treatment 5 to 10 years from now. And so I think that's a reasonable expectation with this as well. So yes, you can. What I recommend to my patients, I mean, most of my patients are on 2 medications. They're a little different, Flomax, or there's a number of medicines like that, and then finasteride, and there's a number of medicines like that. And a lot of patients are on both. And so you know, basically, I take people off of the Flomax. I generally keep them on the finasteride medication, and the rationale for that is because Flomax works by symptomatic improvement. It relaxes muscles at the bladder neck. You don't need that anymore. That obstruction has been resolved. The finasteride, on the other hand, I like to keep people on that medicine, and the reason that I do that is that, as you know, as the question was asked before, do you need to have this done again at some point? And I think, I don't know this, but my suspicion is that if you stay on finasteride, the time that you would need to have this done again is a lot longer, because the finasteride works to slow the growth of the prostate. So the goal is to keep the symptomatic improvement that you get from Rezūm for a longer period of time. And by the way, you know, just 1 second. And by the way, you know, the testimonial you heard from the patient about the dizziness and whatnot, that's from Flomax. You know, finasteride really has no side effects. So, you know, you don't know you're on finasteride when you're on it. So I think it's not really a medicine that there's really a big downside to staying on it. In patients that have had a previous prostate procedure, I am not currently offering this procedure. And the reason is because after that procedure, you can get a lot of scarring in the prostate area. And so I want to have something that I can, you know, cut out the scar with. And so generally for patients that have had this treatment, have had a TURP or a laser done before, this would not be my first choice for those patients. Just because this is just so simple. All you're doing is just sticking a needle in the prostate and killing some tissue. You know, you're not really in the position to cut out scar like you might have after a procedure like you had. I really would recommend that, you know, if you're not a patient of mine, then you see, you know, your doctor that you normally see and discuss it with them and see if they think you're a good candidate for it. Because, you know, there are some patients that are not good candidates for this, and I think it's important that you get that gets assessed. And if, as I said, Dr. Fitzgerald has done this. Dr. Brightboard has done this as well. So I don't think Dr. L is doing this procedure either. So if this is a procedure that you would want, then I think she would refer you to me to have it done. Well, if nobody else has any questions, I really appreciate you all coming out, and hope to see some of you in my office.